Hi, I'm Dr. Mark Beaird, and I'm an OBGYN hospitalist for the OB Hospitalist Group for two programs in Texas. Today, I'm going to share with you a story about a patient that I cared for on one of my recent shifts and the work I do as an OB-GYN hospitalist. It had been an exceptionally busy day on labor and delivery. All of our labor rooms had been full for most of the day, and it seemed like as soon as we deliver a patient, another patient would arrive in labor. It was shortly after midnight when a nurse called me to come emergently to her patient's bedside because her patient was hemorrhaging. Before continuing on with my story, let me give you a little background. The patient had been admitted at term and was being induced for hypertension in pregnancy. She had been admitted and was under the care of an excellent and very attentive OBGYN in our community. Because everything was so far routine, the patient's OBGYN was at home. Everything was simple and uncomplicated until suddenly it wasn't. The patient's husband came out of the room and called at the nurse at the nurse's station that his wife was bleeding. The nurse went to the room and found that the patient was actively and profusely bleeding from her vagina. I was called emergently to the room and arrived within a minute. When I entered the room, I didn't know the patient's story. I could see that the patient was actively bleeding. My first concern was that she may have had a placenta previa that somehow may have been missed. I asked for an ultrasound to be brought into the room, and while this was being done, I was able to gather the history that the patient had been induced for hypertension and that all had been going normally until 10 to 15 minutes ago when she began experiencing increasing and severe back pain. At the time of my arrival in the room, the baby's heart tracing was normal. I was able to quickly perform an ultrasound to rule out previa. This allowed me to examine the patient and confirm that she was only 3 to 4 centimeters dilated and delivery was not imminent. She was indeed actively bleeding at a rate of several hundred cc's per minute. During the 3 to 4 minutes that it took me to gather her history and evaluate her, the fetal heart tracing changed from normal to showing decelerations to showing a prolonged deceleration that showed no signs of recovery. I explained to the patient and her husband that we needed to proceed with an emergent and life-saving C-section because of active hemorrhage and my suspicion for abruption, a condition where the placenta prematurely separates from the uterus. I immediately went to the labor delivery charge nurse and we began making arrangements for a cesarean section. Unfortunately, it was an unusually busy evening on labor delivery and another cesarean section was in progress. While the patient was being prepared to go to the operating room, the charge nurse was able to arrange for an anesthesiologist and surgical team from the main operating room to come to labor delivery to allow us to go ahead and proceed with our emergency C-section. We took the patient emergently to the operating room in labor and delivery while the patient's primary OBGYN was en route. I started the emergency C-section under general anesthesia. I was able to make the incision for the C-section within 13 minutes of the diagnosis of abruption and the decision to proceed with the C-section. The baby was delivered less than 2 minutes after making the incision, and abruption was confirmed. The baby was initially blue and floppy and had an APGAR score of 1 at 1 minute. However, the baby began to soon cry under the care of the NICU team and had a normal APGAR score of 9 at 5 minutes. Fortunately, the baby had a normal umbilical cord pH, indicating the baby would have no ill effects from the abruption. The patient's primary OB-GYN arrived as I was closing, and we were able to complete the case together. The patient required a blood transfusion because of her acute blood loss, but otherwise did well. Although this was one of my busiest shifts as an OB-GYN hospitalist so far, I finished my day with a rewarding feeling that I'd saved the life of a mom and the life of a baby that day. I practiced as an OB-GYN, a general OB-GYN in a group practice for 20 years and then worked in residency education for 7 years. I've been working as an OB-GYN hospitalist for the OB Hospitalist Group for the past 7 months. I enjoy working as an OB-GYN hospitalist as it allows me to be totally focused in caring for patients in the hospital. As an OB-GYN hospitalist, I have several roles. First, and most importantly, I'm able to provide a layer of safety to all of our patients in labor and delivery by being immediately available for emergencies like the one that I shared. Another important role I provide is to serve the OBGYNs in our hospital. I know what it's like to be in full-time practice and having to balance caring for laboring patients in the hospital, and in some cases, multiple hospitals, maintaining a busy office schedule, doing elective surgery, and being available for family. As an OB-GYN hospitalist, I'm able to assist the community OB-GYNs in caring for their patients at the hospital by evaluating their patients when they come in for triage, assisting in the management of their labor, providing coverage when needed, and responding to emergencies like the one I shared. This provides support to the OB-GYNs that we serve in our hospital, providing them some personal margin and margin for practices in their family. I'm Dr. Mark Beaird, and this is a little look into what I do as an OB-GYN hospitalist for the OB Hospitalist Group.